It is with a great pleasure that I present Dr. Evi Clearing, who studied biomedical sciences at KU Leuven in Belgium. And then she worked 1 year at the Scientific Institute of Public Health in Brussels. And afterwards, she went back to KU Leuven to pursue her PhD in biomedical sciences. And actually, her thesis was something very, very nice, because she used a rhesus monkey for amygdala kindling as a model of temporal lobe leptogenesis. And it is a few years ago that she has been working as a coordinator of the epilepsy monitoring unit here at the University Hospital in Leuven. So, Evi, thank you very much for being here. And yeah, the floor is yours, and it's of our participants.
Yeah, thank you very much for the invitation and for the opportunity for me to be able to talk about IctalSpect, something that I also did during my PhD with the rhesus monkeys. Now, yeah, we do it in the EMU almost weekly. So it's a topic that I'm really interested in. I'm really enthusiastic about. So I guess you all got the lecture beforehand. So if there are any, I didn't prepare anything now, but if there are questions or remarks or whatever, just shoot.
Jose, please, yeah.
Yes, thank you so much for being here with us, Dr. Clearing. I just have a technical question. Sometimes the patient is waiting for the IctalSpect, and if the patient gets admitted the night before, so let's imagine that the patient has, I don't know, 4 seizures. Is there a minimum waiting time in order to inject the seizure for the IctalSpect? I mean, the in-between seizure time, or like a recuperation time, something like that, a minimum waiting time between seizures?
Do you mean between, if you want to inject one IctalSpect, or?
Yes,
yeah.
My question is because sometimes the patient is, overnight the patient has 12 seizures, and we are waiting for the radiopharmacy to have the tracer. So I don't know if it's like if we inject a seizure in the mid-morning, but the patient had a lot of seizure before.
No, I think there is no guideline about it or no rules about it, because in the end, like, you have your hyperperfusion during the seizure, and then your post-ictal switch, but this doesn't last for hours. So if you have a new seizure, it means that you have again the hyperperfusion in the seizure onset zone and propagation pathways. So for IctalSpect, also because I think on the other hand, to acquire an IctalSpect is quite hard, and you have to be lucky to have a seizure. So you cannot waste a good seizure if you have the tracer ready. In the literature, some groups say for the inter-IctalSpect that patients should be seizure-free for like 24 hours or something. But also for us, we don't really keep track when was the last seizure before the inter-IctalSpect. But we do EEG monitoring during inter-IctalSpect to make sure that there is no subclinical seizure going on right there.
Okay, thank you so much.
Atsuhiko, thanks.
Hi, my name is Atsuhiko from Japan. I'm a neurosurgeon in Japan. So thank you very much for your very beautiful lecture. So my question is the orientation of the origin and the setting, the origin. So where is the best suitable place for set the orientation? Because the raw data of SPECT is usually so very crowded and broad. So it is very difficult to make the orientation of the raw data. So which part is very suitable or famous point for orientation?
I think it doesn't really matter that much as long as you put the point of the origin in more or less the same area. So in like noisy
Ocular
SPECT
commission.
data, for example, the anterior part of the ventricle is very easy to recognize. So just something in the middle of the brain, or like try to aim more or less for like, I generally aim more or less for AC, for the anterior commissure. But because you set the orientation and all the images at roughly the same position, just to help SPM to make a better co-registration. So it doesn't need to be exactly at the same point, because then during the official co-registration, SPM corrects for this.
Okay. Thank you very much.
Also posted in the chat one question that Angelica sent, but also I will read it. She says, thank you so much for the fantastic tutorial. I followed the tutorial and appreciated sending unidentified data, which made the learning experience fruitful. And she is asking about the origin rotation, because she says, how do you open the view to change the origin of the images? Because she said she have looked at the same part of the video and missed how you open the menu. And she attached a screenshot, this part where you do something with your mouse and the menu appears magically.
Wait, I'm trying to save the screenshot, but yeah, basically you I cannot open the screenshot.
Okay.
But
Sorry, yeah.
But basically, like to call SPM, you just type SPM or SPMPet in the main window of MATLAB, and then you click on display. I think it's called display, where you can just see one image, also with the origin, and there you can change the parameters.
There was recently a publication about ICTAL SPECT and the experience of other centers, and especially it was in an Australian center. And could you tell us a little bit about your experience? How many patients actually get expected as per admission, or is actually very low, or almost all of your patients does it?
I think we have a very good success rate. Depends, of course, on the seizure frequency of the patient. I don't really know the numbers. There was one paper several years ago when someone of nuclear medicine checked the injection latency, and there it was around 20.5 seconds on average, with the majority earlier than, I think, 15 seconds or something. But we generally have 2 patients a week admitted for ICTAL SPECT, and we miss very little seizures during the SPECT hours, because we always have someone monitoring. Sometimes we have patients who have who just do not do a seizure during the 5 days of monitoring, or patients who do only seizures at night, or quite often because we do medication reduction. So sometimes we are just waiting for a seizure, and then because at the Thursday, like we admit on Monday, and then on Thursday night, the concentration of the anti-epileptic drugs is so low that sometimes then on Thursday night they do focal to bilateral tonic-clonic seizure, for which they get rescue medication, and then basically your Friday opportunity to SPECT is very low after the rescue medication. But I think we don't miss that many seizures during SPECT time. If we have patients with quite some seizures but that are very, very short, then we have in the afternoon one of the EMU nurses sitting next to the patients to be able to catch the seizure. But this is quite rarely that we have to do this.
Maybe something that might pop up is in your examples you also showed the Akai, like it's kind of way of analyzing PET. Can you tell us a little bit about it?
Yeah, what we do there is like Akai stands for anatomy corrected asymmetry index. So it's basically you take your reconstructed FDG PET image, you match it with the gray matter map of your MRI, and then we calculate like left-right % differences in FDG uptake. only in those voxels that are like similar in the both hemispheres. So if you, for example, have a patient who already had a resection zone, it doesn't take into account the resection cavity. So if you just look at the raw reconstructed PET images and you have a patient who already had a resection, you see like a big blob of hypometabolism in the resection zone because there's nothing. So this corrects for it. And what we like to do in Leuven is actually to have your MRI and to use all these overlays. So to use the overlay of the morphometric analysis to overlay like the SPECT, and this Akai allows you also to have an overlay or some quantification on the hypometabolism of the FDG. So for us, we basically have, in the whole pre-surgical evaluation, we have every specialist reads the scan. So we have a neuroradiologist reading the MRI, we have a nuclear medicine specialist for the FDG and the SPECT images. And then I basically do post-processing on all the modalities and put everything together in one image space. So then the neurologist can compare all the images in the same space and overlay all of them on top of each other. And this way we also kind of like double check the results from the specialists in all like their own disciplines. And we have like also a collaboration, for example, if MRI was given as MRI negative by the neuroradiologist, but the morphometric analysis shows something, we go back to the neuroradiologist and say, yeah, can you double check, especially in that area? Can you see a focal cortical dysplasia there? So it's it's one big discussion.
Any other questions or comments? Okay.
Yeah, I just have a question. Is like I'm just being curious. Do you call for an equal SPECT for every patient undergoing a pre-surgical evaluation, or is there just a special prerequisites or something like that?
No, we do it during the 5-day emo monitoring for every patient for pre-surgical. I know a lot of centers start with MRI and EEG and see what happens there, and then go in a second phase to PET and SPECT. But we go directly from the first phase for like MRI, PET, SPECT, and the emo recordings. But I think it's a matter of habits in every center, and also the availability, of course, of the methodologies. And for example, we don't have a MECH, so we do very little MECH, but if we think we need it, we send patients to another place. So it's both the experience, the habits, and the availability of techniques, I think.
Sure. Yeah, because I just searched in the literature and there are no specific guidelines. There's just one pediatric one. And they say that you could request it if you have like discordant data. So, but it's a bless to have it in every patient, right?
Yeah, of course, because it's the only imaging modality where you can image the seizure onset zone. But indeed, there are no clear guidelines. But I think it's similar for PET, I think. I don't know if there are clear guidelines for when you should do a PET during the pre-surgical evaluation.
Yes, exactly the same. They say that just in pediatric that if you have like a discordant data, you could request like these functional imaging techniques. Yeah,
I think most centers do like the long-term emo recordings with an MRI, maybe with MECH and electric source imaging, and then see if they need more information, and then they go in a second stage to PET and SPECT or other data. But yeah, I think it's mainly habits and experience of every center. But it would be nice if there would be like more clear guidelines on also to, I don't know, to limit resources or to limit, I don't know, radiation exposure for patients or whatever, all those things.
But I want to thank once again Dr. Clearing, because she's been very helpful, and the resources she presented will be used by many people, as are already used in some places in the world. So thank you very much.
My pleasure. And I have to thank Patrick Dupont for like giving the script and making the script available. But indeed, he also went to that very like a lot of different centers to implement it there. And also, if there are any more questions in the future, yeah, you have my email address in the presentation, so feel free to contact me for any type of questions.